Hello and welcome to a new Top Doctors interview. Today, I am delighted to welcome Mr. Vikram Dhar, highly regarded consultant ENT and head and neck surgeon with practice in Kent, who will talk to us about glue ear. Hello, Mr. Dhar, how are you today?
Thank you. Hi, I'm good, thanks. I'm excited to talk to you today about glue ear, as you say.
Perfect. Before we dive into the questions, Mr. Dhar, would you like to start by telling us a bit about yourself and your trajectory?
Yeah, sure. So as you say, I'm an ENT surgeon down in East Kent, so Canterbury and Ashford area mostly, and also a little bit in West Kent at Bundon Hospital. My NHS practice is full of general ENT and head and neck surgery as well. And that's pretty much reflected in my private practice too. I, along with many other ENT surgeons, provide care to patients that suffer from glue ear. And often that's both advice and surgical. But from a sort of a personal perspective, I thoroughly enjoy my role as an ENT surgeon. I think it's an exciting surgical specialty, lots of intricate operations which we enjoy, and enjoy the broad range of patients that we see. We often see people literally from cradle to grave, so it's quite a nice feeling to be able to help people at different stages of their life. But on a personal level, busy surgeon, busy dad, try to fit in a sport whenever I can. Live in a very beautiful part of the world, and considering all the turmoil that's going around the world at the moment, we're fortunate to live here. So thankful for that.
We indeed are. Fantastic. We'll get right into today's topic then. Glue ear is a very common condition that affects 8 out of 10 children in the UK. What exactly is glue ear and how is it caused?
So glue ear, or medically we call it otitis media with an effusion, where fluid ranging from very serous fluid, so quite thin fluid, to very thick fluid, starts building up behind the eardrum. So the ear is split into 3 broad sections: the outer ear, which is the outer layer of the eardrum, and the ear canal, and the pinna, this bit of the ear, and the middle ear, which is behind the eardrum, that space that we all know that fluid builds up. And then the inner ear, which is in the balance organ, and the cochlea, which is embedded in the hard petrous bone of the ear. So the bit we're talking about is the middle ear, the bit behind the eardrum. And the reason why it builds up, it can happen in adults or children, but the reason why it builds up in children is typically that the tube that equalizes pressure between the ear and the back of the nose doesn't work so well. It's quite immature, it's quite short compared to an adult, and it's quite horizontal. And because it doesn't work very well as children are growing up, then fluid can build up behind the ear, which causes them can cause lots of problems. I mean, you say 8 out of 10 have glue ear, but that's not at one time. I mean, kids will often have glue ear, for example, when they have a cold and it settles down. Some children will have it extended, for an extended period, and then need intervention. So it's very common, but it's not all the time.
I see. And besides the fluid, what symptoms or signs exactly do they indicate the presence of glue ear?
So the number one thing is hearing loss. So the analogy I often give children is that if you imagine you jumped up and down on a trampoline, the trampoline being the eardrum, and it was a normal trampoline with air underneath it, you would bounce quite high. But if you jump up and down on a trampoline on top of a swimming pool, where the trampoline's touching the water, then you're not going to bounce as high, and nor the sound waves on your eardrum. So you get a conductive hearing loss. So the conductive hearing loss is where the sound waves aren't getting through the hearing mechanism to get to your optimum, to your inner ear, to your optimum hearing level. A silly example of this that you can try at home perhaps is that if you have one-sided glue ear, it's a bit like having your finger in your ear, because now I've created a conductive hearing loss. So if I scratch the top of my head and ask myself where I can hear it best. I can hear it best in my conductive hearing loss ear because the sound waves are going through my skull vault straight to my inner ear. And the same thing happens with a conductive hearing loss. So number one symptom is hearing loss. Now, clearly in a child, they're not necessarily a 3-year-old, not necessarily going to come up to you and say, Daddy, I've got a hearing loss, unless he's, wants to be an ENT surgeon one day. But no, in all seriousness, they may say, they may not be able to have such good speech language development, for example. They may not answer to their parents when they're called with a whisper. I often say semi-jokingly to parents, if you whisper to little Johnny behind him, chocolate, and he still can't hear, that's a concern. But often children of that age, in my experience with boys, they will have selective hearing, which is a whole different problem. Testing your child, whispering, treats behind their back, and they still can't hear, there may be a hearing loss. And obviously, glue is not the only cause of hearing loss, but those are two common. The main issue is hearing loss, but also in a young kid, it can cause a degree of imbalance sometimes. And of course, if you've got fluid behind the ear, yes, it's sterile, there's no bugs in it. But the only connection to the outside world, so long as he hasn't got a hole in the eardrum, is via this eustachian tube. This tube we were talking about. And at the end of the eustachian tube is the back of the nose, and the back of the nose is full of bugs. So if you get a cold, or there's plenty of bugs in the back of the nose, and they in effect crawl up into the middle ear, you can then get an acute otitis media, so an ear infection. That would be a problem with pain, with a temperature, potentially with a perforation and discharge, and patients tugging on the ear and that sort of thing. So glue ear can predispose to middle ear infection, which can be quite troublesome to a child.
As you have mentioned, Mr. Dhar, glue ear can also occur in adults. How does it present, or are there any differences in symptoms between children and adults with glue ear?
I mean, the most common presentation of glue ear in adults is after some sort of upper respiratory tract infection. Patients had a cold, they suddenly can't hear very well from one side or both sides, because you can have a glue ear in both sides. And you can even try the scratch test, and it'll be positive, so long as they haven't got an underlying nerve hearing loss, which can confuse things. And the patient will be able to vocalize the fact they can't hear very well. The big difference is that in adults, we're concerned that it may be a sign of, however rare, a nasopharyngeal cancer. So going back to what we were talking about, the eustachian tube, the eustachian tube finishes its anatomical position in the nasopharynx. That's, if I draw a line here, 7 centimeters back, above the palate. And if a nasopharyngeal cancer is growing, it often presents. So when I say often presents, as cancers often present with glue ear, but most glue ears aren't cancers. It presents with encroaching on the eustachian tube orifice, causing it not to function, and fluid builds up, typically in one ear, but sometimes in both. So in my practice, and there are certain risk factors I should add for nasopharyngeal cancer. So people of Chinese origin, particularly Southeast China, because their nitrous amine consumption or EBV exposure, do have a higher incidence of nasopharyngeal cancer. So those patients I'd be more concerned about. But if a patient's had a cold, they then get an effusion in the ear, then it would be reasonable in the first instance to regularly pop their ears, maybe 5 times in a row, 5 times a day, perhaps take a week of otrivine nasal decongestant no longer, to try to decongest the nose and see if the symptom goes away. But if it doesn't go over a couple of weeks, then they probably should have the back of the nose inspected to ensure there's nothing growing there. That's the key message with regard to adult persistent glue ear.
How do ENT specialists check for glue ear?
Okay, so there are the primary way we do it is by looking in the ear under the microscope. And often patients, I didn't mention earlier, often patients will know they've got fluid because a bit like a box with fluid in. If you turn the box, the fluid sort of shifts inside the box. because it's not completely filled. So they'll notice when they turn their head, they can feel the fluid move around, might get some crackling, popping perhaps. But when we look in, we often can see in a fusion. Now, I remember when I was training, I heard that they ask a bunch of ENT consultants, look in an ear, is there glue, is there not? It's a binary answer, yes or no. And only 7 out of 10 times they're able to get it. And putting that in perspective, a monkey is only going to get it 5 times out of 10. So perhaps the ENT surgeons aren't so good. So what we do, apart from just looking in the ear, is we get a audiometry test called a tympanogram. So a tympanogram is a little puff of air that goes down the ear canal, and it measures the compliance or stretchiness of the eardrum. Now, if there's glue behind the ear, the eardrum doesn't move, so you get a flat trace. Now, there are other causes of flat trace, but primarily, if you think there's glue and there's a flat trace, then there is glue. So those are the mechanisms about how to find if there's glue here too. And of course, if you came to see me, you'd have a pure tone audiogram as well. And just going back to my scratching head thing and a conductive hearing loss, on an audiogram, you would see that an audiogram is a hearing test. The audiogram measures 2 things. One is bone conduction. So that's remember going back to the inner ear in the petrous temporal bone. So how good is that? So that will be your upper threshold, your best threshold. And then the gap between that and what you're actually hearing, so if I click my fingers, what I'm actually hearing, the distance between those 2 measurements is what we call the air-bone gap, or how much hearing are you losing because of the failure of your conductive mechanism of hearing to work very well. So in glue ear, you would lose some of that, so you'd have some air-bone gap. So we would see that conductive hearing loss with a flat tympanogram, and probably with us looking in your ear with microscopy, that there is glue. But we also have to rule out other causes of conductive hearing loss. You might have wax in the ear, you might have perforation, you might have otosclerosis, but lots of other causes. But that's how we go about it.
Yeah. And what is treatment recommended, Mr. Dhar? And what options are there?
Yeah, so number one, once you ruled out in an adult, there's no nasopharyngeal cancer. In an adult, if you have 2 consecutive conductive hearing losses that fit a certain criteria, usually 3 months apart, then we would suggest the possibility of local anesthetic grommet insertion. Now, grommets are little plastic tubes that we fit in the eardrum that allow the ear to ventilate. Yeah, they do immediately cause the fluid to come out, but also they stop it from building up. That works very well. But in an adult, person may choose to not live with a hearing loss or have a hearing aid. That's another option. Now, in a child, obviously, a hearing loss is much more concerning. The reason being is we're learning all the time as a child, and we don't want kids to miss out. So it's crucial that if a child has a hearing loss of any kind, that parents objectify it, so a hearing test. So, after the age of 3, they become reasonable, and the older, the more accurate. And if there's a persistent conductive hearing loss, then grommets may be appropriate. We do have discussions with parents about hearing aids. Very rarely is that taken up. And if it's persistent glue ear and a child has adenoids, those are the big tonsils, if you like, at the back of the nose, then it may be the case that we have to remove those as well, which may be on the first or second sitting, depending on the clinical picture. But we always try to manage things conservatively in my practice. But what I mean by that is that if we can avoid surgery, I think it's generally a better thing if we can. What we tend to do is suggest that children, in the first instance, might use something called an Otovent device. So an Otovent device is in effect a balloon the child finds very funny, and they can try to blow it up on a daily basis. And by blowing that up, it does help the eustachian tube function. If the eustachian tube function improves, it may be that the effusion gets better. So I do like to see 2 hearing tests 3 months apart. And if they're, despite the conservative measures we talked about, persist, and the child is, often it's really important for all doctors, nurses, etc., to listen to parents, because mums and dads generally know what's right and wrong with their kids. Is if they are affected by their hearing loss in their learning, particularly, then intervention is appropriate. And another message to parents: it's really important to speak to your children's teachers about this too, so that they're aware of the child's hearing loss and perhaps instigate, sign, or ensure that, especially these days of wearing masks, that they can lip read, because often kids do without even knowing it, or they position themselves in class so they can hear a little bit better until a management plan is implemented.
Perfect. Those were all of our questions, Mr. Dhar. It's been a pleasure to have you. I would like to thank you for being here and being so thorough in your explanation about Glue Ear.
Brilliant. It's been a pleasure.
I would also like to remind our audience that if you or your child have Glue Ear and you would like to have it checked, do not hesitate to visit www.topdoctors.co.uk, where you can find out more about Mr. Dhar and book a consultation with him. Thank you again, Mr. Dhar.
Brilliant. Take care. Have a good day.